Jorge, let's turn to you. What is your personal strategy for determining, fitness for chemotherapy, who should be treated, who shouldn't be treated? How do you walk through that?
There's been different systems and scores and things that have been developed to try to determine that. Of course, the simple way that for many years we all did, and it's still being done, unfortunately, is by age. And you go to the literature and you see studies that talk about elderly AML, and they talk about patients over the age of 55, and that hurts. So evidently we know that that's evolved way beyond that, and it has to do with probably age is much less minimally involved in many instances, and it's all about other elements, comorbidities, and other important aspects of the patient. A patient in their 60s may be very fit and in great condition to tolerate, in the late 60s, to tolerate intensive chemotherapy, whereas a patient in the late 50s, because they have prior histories of cardiac issues or renal dysfunction or whatnot, may not be able to take chemotherapy. There are scoring systems that have been developed. I don't think there's one that's been universally accepted. Some people use the comorbidity score, some people use others. Certainly your clinical judgment carries a long way, and I think that in most instances, well, that's what I use more than a specific score or a specific system that's been published. I think for clinical trials and for other aspects, it's good to have a more uniformity, but nothing, in my opinion, nothing beats your clinical impression of how a patient might be able to tolerate therapy. And certainly, I'll emphasize this again, it's not the age. The age is a factor, of course. When a patient is in their 80s, well, you have to acknowledge that their heart and their kidneys are in their 80s. But it goes well beyond the age.
But you focused on patient-specific factors, age, comorbidities, performance status, for example. In older patients, frailty indices scores have been used. But how about leukemia biology? For example, poor risk cytogenetics or poor risk mutational profile. Are you thinking about less intensive therapies or non-intensive therapies for those patients?
Well, because the therapies are evolving, certainly in some instances you are. You are talking about a patient, in the old days you had a patient with high-risk features, and all we knew is to intensify the therapy. Now, if you are thinking about a patient with high-risk features that may imply a specific mutation or some other factors, you may be thinking about incorporating a targeted agent that may not need intensification of the chemotherapy component if you're going to use it in combination, but rather addition of an agent that's more specific. So because we're deviating from just intensifying chemotherapy into a more selective approach, yes, it definitely has to be part of your treatment strategy. But it's not necessarily whether you're going to use a high-intensity chemotherapy versus a low-intensity chemotherapy, but rather what combinations or what strategies you're going to incorporate.
We've focused a lot on our therapy for AML being driven to cure of the patient. And that's how it's been for decades. And maybe it's kind of slowed down drug development in defense of the FDA. We haven't been able to do what we think we should be doing, curing more patients. But maybe we're not focusing on the right thing, especially for the majority of our patients who are older, where quality of life becomes just as important. And there are drugs now being approved based on kind of quality of life. Dan, do you want to say a word about that?
Yeah, well, I think this sort of less intensive approach for, older patients is, has borne fruit recently. I think we're going to get to some of these treatments later, but venetoclax and glasdegib, we already sort of discussed IDH inhibitors or other targeted therapies. I think, those might continue to have a role, and they may continue to be extended beyond where we currently think of them, which is more focused on the older patients who aren't fit for intensive chemotherapy. But perhaps, like Harry suggested, maybe if we start to think about, not just inherent patient-related fitness issues, but more disease-related fitness issues, such as, is this a disease that's likely to respond to an intensive chemotherapy approach, and using the biology of the disease comorbidities to help make that decision. And when you have certain risk features that suggest a poor response to intensive chemotherapy, maybe thinking about alternative therapies, even if they could be quote unquote fit for intensive chemotherapy. I think it's going to be really interesting to see how that evolves. That I would predict that will spread to those areas.